So fourth, how about the safety profile? It appears that for all SGLT2 inhibitors, the safety profile is well established, except that in the canagliflozin study, we can see a numerically increase in the fracture rate as well as the amputation rate. So, but this was not observed in other two studies. So to conclude, SGLT2 inhibitors appear to reduce MACE in patients who have established cardiovascular disease, which is actually a missing piece of the puzzle because as we showed before, patients with diabetes and especially long-standing diabetes, they appear not to benefit from other drugs in terms of cardiovascular events, but SGLT2 can fill in the gap. So how about heart failure hospitalization and renal protection? It appears that heart failure hospitalization and renal protection, the benefits actually span across the whole spectrum of patients with type 2 diabetes and cardiovascular risk factors. The results of these randomized control trials has been reflected by the newly released 2018 consensus report. So this is a guidance of how we treat our patients with type 2 diabetes. So if the patient has type 2 diabetes and an elevated HbA1c, you should consider metformin, probably because it is cheap. It is safe, it has been used for a long time and has a well-established safety and also benefits profile, efficacy profile. But how about if the patient still needs other medications? Then you should actually look at the cardiovascular risk factors of this patient. In patients who have established cardiovascular disease, you have to know whether they are the predominant cardiovascular disease is atherosclerotic disease or heart failure or CKD, chronic kidney disease. So for patients who have established atherosclerotic disease, then you may consider SGLT2 inhibitors or GLP-1 receptor agonists. However, in patients who have the risk of heart failure hospitalization or chronic kidney disease, then you may consider SGLT2 inhibitor first before you consider GLP-1 receptor agonist. Although in patients who have severe renal dysfunction, like those with eGFR less than 45 ml per minute square, then you may not be able to start SGLT2 inhibitor, and you may need to consider GLP-1 receptor agonist. Obviously, you also need to tailor the medications according to need. You may need to have a better control of HbA1c in selected patients, or you may need other medications like even insulin in patients who have uncontrolled diabetes. So thank you for your time. I hope you have enjoyed the lunch.